Greetings, Dr. Maxey. Can you hear me? It's
Yes.
Michelle.
Hello, Michelle.
Hi, just wanted to let you know we can see you, and I believe your camera is off mute right now,
Yes,
just to make you aware.
very good. I won't.
Can we get, there you go. Thank you. That's it. Simon, if you can hear me, I'm turning over the reins to you. Dr. King is going to ask to share a screen. So you're going to make Dr. King a co-host, and I'll hit you offline about that when he's speaking.
Dr. Janine on,
Yes.
and Dr. George Benjamin.
I am.
Okay. Thank you all.
So it's 12:04. We'll just give people a few more moments to log on. Dr. Maxey, I can see you counting participants. I'm waiting till 30.
Okay.
I see a few more people trying to connect.
Dr. Bailey needs to call in code Simon. Dr. Ron K. Bailey.
Okay, Bailey. Okay. Let me handle that, Simon. You just worry about the stream. Dr. Maxey, I'm going to email that to Dr. Bailey.
Yes. Okay.
Comfortable to begin?
Michelle, I was thinking for the next 2 minutes, why don't we give everybody a chance to say a quick name announcement and where they're from, and then we'll be ready.
Oh, that'd be great. Okay, I think it's probably easier if I just call on people so they don't overlap. And so let's.
Hold on one second, Michelle.
Sure.
Dr. Maxey, I can't find their email address, so can you text me that Dr. Bailey's email address? Thank you. Sorry, Michelle.
No worries. So Martin, why don't you start? Your name and where you calling from?
Funny, Michelle. Yeah, I'll say my name, Martin Pratt, calling in from Philadelphia, Pennsylvania. And I want to know what Michelle's drinking.
I am drinking ginseng red tea. Safe.
Very good, very good.
Jerry Maxey. Unmute. Where are you calling from?
Cincinnati, Ohio, Jerry Maxey.
Cincinnati. Awesome. How about David 5? This is David 5, and where are you calling from? Or what about Galaxy S7? You have to take your phone off mute.
I think that's
Victoria?
Victoria, Gaskins, Los Angeles.
Alakimi? I'm sorry, we can't hear you on mute.
That's Dr. Wallace. She's calling.
Dr. Wallace.
She's calling from Lagos.
No, Inglewood, California. I'm not in Lagos.
Last week. Colleges on colleges.
Wonderful.
Told you in college.
Is it Dr. William King?
Yes, hi, William King, maternal medicine, HIV in Los Angeles. Hi, Dr. Wallace.
Wonderful.
Hi.
We're neighbors. Dr. Janine?
Hi, Janine Daly Garnes, adult and pediatric infectious disease in Houston, Texas.
Welcome.
Thank you.
Thurston Bilal.
Herbalist from Los Angeles, California.
Wonderful. Thaddeus?
Thad Patterson from Metro Atlanta, Georgia.
Big Georgia. And Marlon Jones?
Hi, good afternoon. It's Marlon Jones calling from New York.
East Coast, good to see you.
Thanks.
And Mr. Johnson? Ross?
Good afternoon, Ross Johnson, Washington, D.C. area.
Wonderful. And Joy. Unmute. Unmute your screen. There you go. Uh-oh, still can't hear you. Joy Simmons from Los Angeles. I know that one. Welcome, Joy. Who else do we have here? Judy.
Hi, Judy Maxey, Fort Lauderdale, Florida.
Awesome. Is it Suri Rose Johnson? How about WHG2?
Hi, I'm Willie Goffney. I'm sorry I'm coming across as WHG2. I'm a surgical oncologist in Long Beach, California. I signed in today from a different computer, and I guess it's logged into one of my email accounts. So
Awesome. You may be able to change your screen name if you want. In the upper right-hand corner of your Zoom box, there's 3 little dots. Depending on your account setup, you may be able to click on that and hit rename.
okay, I'll try that. Thank you.
Uh-huh. Okay. So Dr. Maxey stepped aside, so I'm going to go over to screen 2. How about Carrie Nero?
Carrie Nero, Brigadier General, retired, St. Petersburg, Florida.
Welcome. Thank you for being here. And Coleman Holmes? Herb?
Thank you so much, Michelle.
You're welcome. Are you ready to begin?
Yes.
All right. Well, I'm sorry I didn't get to everybody on the call, but maybe I'll have a chance to chit chat later. So welcome everyone to this week's edition of Black Health Trust. My name is Michelle. I'm out of the West Coast. I'm in Los Angeles, as you can see by my palm tree. So whenever you lose track of me, I'm the girl with the palm tree in the corner. So I'm your host for today. And today's meeting will be facilitated by the distinguished Dr. Randall Maxey, who's Chief Medical Officer of Advanced Community Medical Care Corporation here in LA. So the mission of the Black Health Trust is to provide credible insights from our community health experts to best serve our communities with a coalition of leading and longstanding Black medical professionals across a diverse spectrum of disciplines in order to offer unvarnished opinions and insights into our physical and mental well-being during these challenging times. So that's the purpose of our mission. I want to share a few housekeeping items for the meeting. 1, please be advised that this video conference is live and it is being recorded, and that participation on this call is voluntary. If you choose to participate on the call and prefer not to have your image and likeness displayed, you have the option to block your image and mute your voice by changing the video and audio settings on your device. Just want to make that clear. Everyone's audio should be muted at all times unless you're being facilitating or being called to speak on. And then once you've spoken, please go ahead and remute your device, just to minimize distraction and noise and background noise. You may enter questions or comments in the chat room, but understand that there may not be sufficient time to address every single question. So we apologize in advance for that, but we'll do our best to get to as many as we can. Please note that the information communicated on this call is not deemed to be medical or legal advice, and you should always consult your own medical or legal professional for advice pertaining to your particular situation and needs. So that said, a big welcome to all of our distinguished physicians and guests. We thank you so much in advance for sharing your time, your expertise, your information and insights with us. We're blessed to have you participate and to care so much about your community. So from the West Coast, East Coast, North and South, again, everyone, welcome to this week's Black Health Trust meeting. May the divine guide our words and our works. Dr. Randall Maxey, I hand it off to you.
Well, thank you so much. I appreciate everyone for joining. And one of the reasons that I asked for people to introduce themselves and where they're from, and we may do later, when this call started, about 12 or 14 weeks ago. It was just a few people who are mostly friends and family. And we were able to do that. This call now is not only the 30 or 40 people you see online, but it now streams to upwards of 2,500 to 3,000 people on the line. But I don't want to use the character that we all care for each other. And I'm gonna read a few things here before we introduce our guest. And the first thing I have is that I am my brother's keeper. I love my brother as I love myself. And we at the Black Health Trust, that we're now called, we're a nonprofit, are dedicated to providing credible information to the communities of color. I'm concerned that there are a number of recent events that have impacted all of us. In my calls around the country and looking at the news, and I ride a Lyft cab every day, I'm still shocked at the number of people who think that people dying has something to do with whether you're Democrat, Republican, and people are not taking into account that almost every nation that I've heard of on earth has a problem with COVID-19, and they don't care who's Democrat or Republican or white or black. But we do know that the numbers that have been coming out are tilted so that people of color are dying more, are affected more. We know that although those of us in the senior range, that's those of us above 60, I'm 61, have more chance of dying from the disease. But this disease does not forgive or forget the 40-year-olds, the 30-year-olds, and even in some case, younger children and infants can be affected. We also don't know the after effects of having been tested positive, either through the swab test or the nose test, or whether you have the antibody test. Are there any long-term effects, even if you survive? We don't know that. We know that industry and government and people are trying to create vaccines, immunotherapy, et cetera. We don't know the results of that. We do know that there's some social issues with those, and we're going to discuss some of that. We have a guest that I'm particularly glad that we have Dr. Georges Benjamin, who's a distinguished physician and the executive director of the American Public Health Association, which is nationwide. We have Dr. William King, a colleague of mine who is an internist, but he's also an attorney. Isn't that interesting? And he also specializes in HIV and infectious disease. A special pleasure to me is that I have a very good friend who was the president of the NMA before I was, a year before, and she had a young teenage daughter that I met, and that young teenage daughter is now Dr. Janine Daly, and she is an infectious disease specialist and pediatric epidemiologist. We also have a number of other notable physicians on the line. I was glad to hear Dr. Ron Bailey join us, another past president of the National Medical Association, a psychiatrist. Dr. Willie Goffney, who my hat is off, he's the president of the Drew Medical Society, one of the largest medical societies in the NMA. And on a personal note, he has been involved in the care of my daughter-in-law, and he knows I salute him a lot. There are a number of other physicians who will probably speak up during the course of the call. But I want to start off with a couple of statistics. As of this morning, the total cases of COVID-19 in the United States were 2,789,678. the total number of deaths in the country was 129,305. In California, the total number of cases is 244,235, with the number of deaths 6,263. In the state of Texas, the total case rate is 183,562, with 2,575 deaths occurring in that state. In Florida, 175,718 cases, and 3,684 deaths. In New York State, not including Manhattan, there's 179,510,000 cases with 8,696 deaths. We know that there's been increased community spread, and I'm going to ask our speakers to speak on that and what that really means and why that's important to us and why we should or should not wear masks. The aim of this call is to get information that protects you and your family, your loved ones, and our country. The last thing I will say is that I spent a good part of yesterday reading the speech that Frederick Douglass gave on July 4th years ago. Now, I always knew that Frederick Douglass was a major figure. In other words, he was a bad dude. But I never really appreciated the depth of his thought process and his speaking ability. And I encourage you to go to the internet and pull up the July 4th speech by Frederick Douglass and read it for yourself. I'd like to call on, as our first speaker, Dr. Janine Daly, infectious disease specialist from Houston, where there is a big surge in COVID-19. Dr. Janine Daly, the floor is yours.
Hello. Is it okay if I share my screen?
Yes.
All right. So what I'm sharing may be a little basic, but it just makes sure that we're all starting off at the same point. You can see my slides?
Yes.
Great. So, we're talking about what we can do to keep our families safe during this pandemic. And one of the things that I found is that, a lot of people are like, well, I'm not in a risk group, so why should I care? And I think that, there is a lot of talk about the risk groups that you just mentioned, Dr. Maxey, but I think we need to reiterate that everyone is at risk for getting this infection. And I think that got lost in the translation. All of us that are human are at risk for getting this infection. We want to think about our friends and family because a lot of them fall into some of these categories that are at increased risk, those who are older, and a lot of what we call the pre-existing conditions or comorbidities, which are listed here. But I think it's important for us to think about that. One, we don't necessarily know if we fall in those risk categories if we don't find out. If we don't go to the doctor, we don't know if we fall into these risk categories. Number two, at least for some of these risk categories like diabetes, it seems that yes, we're at increased risk if we have it, but if we do a good job of taking care of ourselves, like keeping our blood sugars controlled, that we can decrease that risk a bit. So that's something for us to keep in mind. And secondly, we don't always know what's going on with our friends and family. So those who have problems with their immune systems, such as HIV/AIDS and other people who have problems with their immune systems, those with cancer, not everybody's sharing that. And so you have to be very careful about whether or not your friends and family fall into those risk categories. And then, as you mentioned, Dr. Maxey, this is a brand new virus that has never been in people before. So we don't know everything that it can do. We're finding that, maybe for people who have some of these pre-existing conditions, that it makes those conditions worse after they're infected. we're finding that pregnant women may be at increased risk. We're finding that children who seem to not really be affected initially may have some more long-term effects, not often, but pretty serious. And so it's important for us to do what we can do to avoid getting the virus in the first place, because we don't know what's going to happen. And so, thinking through, well, how do we catch it? And, there's been a lot of discussion about respiratory droplets. And so what are respiratory droplets? So, for the lay people among us, these are tiny drops of spit and mucus that we're all putting out every time we talk, we breathe, we cough, we sneeze, we sing. And they're the perfect size if somebody's close enough to you, less than that 6 feet, that it goes directly into their respiratory tract and can start a brand new infection in the person next to them. So this is why we talk about what we need to do to control the spread. The other thing we have to keep in mind for this particular virus is surfaces. This is a hardy virus. So if it sits somewhere and somebody goes off and they coughed or sneezed on a surface, it's possible that if somebody else comes by and they touch that surface and then touch their face, that they can get the virus that way. And then the other thing that makes it very unique compared to some of the other viruses we think about is this asymptomatic transmission, which means that people who don't know that they're sick are actually spreading the virus to people and actually causing severe illness and death. So what can we do? Number one is avoid getting the virus in the first place. And it's kind of like sex. The only way you can avoid it is just not to go there in the first place. And so that's why we're talking about just trying not to go out if you don't have to go out. But obviously we can't all stay home all the time. There are things that need to be done. So what can we do to decrease our risk when we do have to go out? And then knowing the signs that if you're sick, that you're not spreading it. So one, as I said, avoiding exposure, because if you're not out there and other people aren't out there, it's a lot harder for it to transmit within the community. Washing your hands with good old-fashioned soap and water if you can. If you don't have it, hand sanitizer is a great second choice. Avoid touching your face if you haven't recently washed your hands. Staying farther away than that 6 feet for people who don't live in your household. Covering your face in public. What that does, we know that if you're sick and you may not know it, or you're infected and you don't know it, it decreases the likelihood of you getting other people sick. And if everybody around you does it, it can decrease the likelihood of you getting sick as well. So it's another way that we're taking care of each other as part of our community. Covering your cough and sneeze, especially if you're at home, because otherwise you should have on a face covering. And then cleaning and disinfecting your surfaces, especially those high touch surfaces in your home. And then know what the symptoms are. So if you're sick, if you've been around someone who you know has been sick in the last 2 to 14 days, stay home. You can have any of these symptoms, you could have none of these symptoms. So you have to really pay attention to how you're feeling. So, you can read through this list, think through if you have even one of these, it's worth it to get tested. Keep an eye out, especially if you fall into those risk categories or you're around someone who does, so you can keep yourself and those you love safe. Thanks.
Thank you, Dr. Janine. I have a personal interest in you introducing yourself, one, because you're new to us and young, but tell us a little bit about your background, where you trained and what you do.
So originally from Houston, Texas. I went to Princeton for undergrad, majored in molecular biology, went to Harvard for med school, did my residency here in Houston at Baylor College of Medicine, Med Peds, internal medicine and pediatrics. And then I actually, my dream job was to go work for the CDC as an epidemic intelligence service officer. So I did that for a couple of years after residency. And then decided I wanted a master's in public health because I really enjoyed epidemiology. And so I went to Hopkins and got a master's in public health. And then I came back and I did a combined fellowship in adult and pediatric infectious disease here again at Baylor College of Medicine. And I'm currently practicing here in Houston.
Well, thank you. You must be about 75 years old to accomplish all that. My goodness.
Oh, thank you. I look good for my age, right?
There you go. Thank you so much.
Thank you for the opportunity.
We're going to hold questions and then we're going to sort of put them together and ask everybody. I'd like to introduce Dr. William King. Dr. William King is a past president of the Charles Drew Medical Society. He is not only a physician, but he's also an attorney. He's very trusted among the professional community here as well as the lay community. Dr. William King, the floor is yours.
Thank you very much. Simon, may I share my screen, please?
If you look on the bottom in the middle, you'll see the option to share. There you go.
Great. Okay, great. Thank you, everybody. Thank you, Dr. Maxey, for inviting me to this important event as well, too. What I have done is just think a little bit about what I've been experiencing as a physician and as a father, as a husband, and as a son over the past 6 months as well. So on or about March 15th, 2020, we physically closed our doors to my medical practice. We physically closed our doors to our home. We did this for a sense of protection for both our patients, our team members, and ourselves and our family members, but we also did it as a fear of the unknown. I realized that we have been fortunate and we've been blessed because we've been able to have a home to shelter in. We've had a profession and we've had resources that we could adopt to virtual interactions. We have the technology to be able to construct a virtual community for our work, our children's schooling, and we've had funds to be able to obtain supplies. We've been very blessed on that options. But because of the paucity of information, we were mainly reactionary. And we created sandbags against the growing tide of unprecedented disease, death, and changes, what we had once perceived as being normal. So now as we are perceiving and we are preparing for a potential resurgence, we're not as uninformed as we were back in March, but yet our level of certainty, in my opinion, is not significantly greater. So when I think about a disease process, and thank you, Dr. Daly, for your introduction to this information, I think about this in terms of prevention, treatment, recovery, and then also prevention in terms of making sure that the reinfection does not occur or there's not recent or debilitation as sequelae of the current disease. So prevention, and this is for both us as providers as well as people who are not providers, but who are also being able to look for information, make sure we're getting our information from trusted resources. The fact that you're having these weekly meetings is very important because you're able to have an open discussion that's multidisciplinary, not just in terms of providers, but in terms of social workers, teachers, educators, family members, religious individuals as well, to try to see if we can put a consensus with regards to how we're going to take care of our people. So look at the information that you're getting. Make sure we're not just repeating Facebook facts. Seeing if the information can be justified as well. Looking at the population sample size for the studies that we're looking upon. Right now, because there's a lot of information that's coming out with regards to COVID-19, a lot of information is not peer reviewed. We still have to go back to our training to make sure that we can trust that information that's coming out. As Dr. Maxey said, I'm an HIV specialist as well, and I think there are a lot of parallels between COVID-19 and HIV within the beginning. Both of viral illnesses, both unfortunately are impacting African Americans, Black and Brown communities, and both can also, the number of new cases can be impacted by testing and knowing one's status. Once you know one's status, and everybody here on the call and our friends and family members should also be tested as well for COVID-19. I know earlier in March, who was becoming tested and the risks for being tested are much different than it is now. But I think in order for us to get a handle on this disease process, we need to at least have a baseline. With that baseline, we're able to make adequate decisions and decisions with regards to healthcare. We're able to self-quarantine to see our doctors. More importantly, we're able to reduce the amount of disease that's being transferred to others by isolating ourselves and informing others who are in contact with us about the need to be tested as well. We could also get access to quicker to resources as well that might pertain to COVID-19. In California, there are some places called Project Turnkey, where it's a nonprofit that are actually letting individuals who do not have homes, who are homeless, or who need to shelter in place, who do not have the adequate place to do that, they're finding places for them. With regards to our providers, a lot of us provide, some of the providers, myself included, just see patients inside the clinic. We don't do the inpatient, outpatient anymore. But it's very important for us, particularly because there's a lack of communication, I would say now, particularly with regards to COVID-19 and communication barriers with regards to technology. It's very important for us to have our inpatient referral network together. It's important for us to know our hospitalists by name, important for us to know our infectious disease specialists, our intensivists, and our critical care specialists. Oftentimes, the family members of patients are unable to contact these providers. If we know that these providers are parent, and we know these are individuals that we can trust, we can easily get that information back to the patients, family members as well. The outpatient referral network. Unfortunately, I missed your last town hall with regards to mental health and COVID-19, but I'm seeing I'm seeing an increased number of anxiety and depression that we're screening. And we're finding people, the ones who previously had anxiety and depression, that's been exacerbated. And individuals who do not see a way in terms of staying at home or sheltering in place or have access to care, I'm seeing their anxiety and depression as well too. Nutritionists. Dr. Daly had referred to chronic illnesses that may exacerbate conditions and morbidity and mortality with regards to COVID-19. And we know by these conversations that we're having, we know that several of these diseases can be abated or prevented with regards to nutrition. And I believe Dr. Maxey has a nutritionist that he works with. I have a nutritionist that I work with as well too. And also social workers, because as in terms of nutrition, a lot of physicians, we're not trained in nutrition. We're not trained to deal with social work issues and to find these type of resources. And making sure these are within our referral network is very important. It's also important for the family support networks. Again, now that the smoke has been clearing a little bit, we see how effective and the need for childcare, even virtual childcare, elder care as well too. Several of our family members may be in nursing homes, skilled nursing facilities. We may need respite care because we're doing care for ourselves, care for our families, care for our children, and care for our patients as well. Online teaching. This has been unprecedented, the situation where we've had to being teachers at home, to take care of curriculum. And a lot of times, I can speak personally, I have a 5-year-old, I have a 6-year-old. The amount of homework, the amount of work that they required us to do was way more than an hour or two per day. And we're seeing already that children are not necessarily learning from this distance-based learning, right? There's lots of frustration that's being reported as well. And access for spiritual support. Again, the mind, body, and spirit are very important. I've been very encouraged by the number of churches that have been able to provide virtual churches services on Sundays. We're seeing lots of individuals, we've seen a lot of death, and we're seeing a lot of morbidity. We've seen lots of individuals, because of this respiratory illness, with this heightened immune response, we're seeing the need sometimes with the hypoxia and the dyspnea for people to be put into intensive care. Therefore, more than ever, it's important for us to make sure our patients, and ourselves included, a lot of times we're pointing at our patients and we don't realize that we haven't done it ourselves, to make sure that our pulse is in place and an advanced directive. A pulse is really a medication order, okay? It basically lets our providers know what our wishes are with regards to if we are incapacitated. It lets us know about whether we want to have life support in terms of critical care interventions. It lets us know if we want to have IV hydration or nutrition. Lets us know, and in this case it's very germane, do we want to be on the ventilator at all? It's very important to have that information available. The advanced directive is a legal document as compared to the pulse. The pulse can be included within the advanced directive, but the advanced directive is actually a legal document. And from the advanced directive, you can assign your surrogate. That's the major difference. The pulse is really a medication, not a medication, more of a physical, clinical order, whereas the advanced directive is a legal document. I don't know what happened here. Sorry. Sorry, I'm having problems with my computer here. So treatment. I apologize for this. As we're seeing that we're having cases where the majority of individuals may have mild or asymptomatic, and well, 20% of the individuals are having moderate or severe disease. With the people that are mild or asymptomatic, we've been recommended by the Los Angeles Department of Public Health, the California Department of Public Health, the CDC, is to try to create these stay-at-home situations, a quarantine or self-isolation. However, what's important for us to do, particularly for the part of the NMA, as African-American providers as well, is to make sure these things are crucially congruent policies, right? Is your home conducive? Is your home life conducive to you having a stay-at-home order? Recently, early on in the course of the disease, course of March, I received a call from a friend of mine who had some friends. There were 11 people in one house, and there were 2 people that are COVID-19 positive, and they were undocumented without insurance as well too. We had to come up with a solution that conformed to their cultural and ethnic ideals, as well as at the same time is to make sure that everybody was safe. Okay. And then standing on the scale is this next one. And I'll make these slides a little bit better. And this is where it comes with the issues of ethics and morals. Ethics are societal standards with regard to what's good and bad. Morals are more the issue of personal issues with regard to what you're determining good and bad is. And this is where I've had to decide, because I'm on the front line with regards to doing telemedicine. I've been doing consults, etc., but I'm not there in the hospital, right? So I feel that I've been more lenient, and I've been trying to be more lenient with our patients, because the overall idea is to protect them with regards to their care and to make sure we're maximizing their outcomes and maximizing their quality of life. I've seen a lot of individuals who are essential workers, a lot of individuals who are just working, and they have their anxiety, their depression, their inability to work has been exacerbated by the onset of this disease. So I've been more lenient. I haven't been fabricating, but I've been more lenient with regards to providing work release with constant check-ins. And I've been more lenient with regards to EDD as well too. I've also been, as I alluded to earlier, I've also been lenient with pro bono work. And yeah, this is something that you as a provider have to assess whether this is financially available to you, or if it's feasible, or if you feel that this is legal or ethical to do. I find that there have been individuals who have been furloughed, who have lost their insurances, who've been lost their, and who have been able to afford healthcare. And because somebody has a change of insurance, I've taken it upon myself to talk to my team and doing some analysis that we've continued care for lots of individuals who've been undocumented, who do not have access to care. We've taken care of them as well too, because we all, I think in this situation, it's all incumbent of us to try to maximize healthcare and to reduce risk. It says the 20% to moderate or severe. Well, the individuals who have, unfortunately, a disease process which is severe enough to go to the hospital, it's important to have both provider training and community training. With provider training, we've been very fortunate, many of us who are at home and doing home practices, we've been very fortunate to be able to become more and have more time to go to CMEs, more time to actually read as well too. So we're able to consult now more with our inpatient referral teams. But it's also important for situations like this, what we're doing right now. It's the community training, for the community to have the language, the lingo, to be aware of medications like remdesivir, to be aware of medications like with the problems we were having initially with Plaquenil as well too, to know about some of the latest development with regards to vaccines. And by having these community forums, it's able for you to have this vocabulary, which is also very important when you're becoming very strong advocates if, God forbid, any of your family members are basically hospitalized because of COVID-19. Oh boy. Yeah, something on my computer, sorry. And then the thing about this is says recovery. One of the issues are, particularly with regards to COVID-19 and hospitalizations, emergency rooms, et cetera, we need to get those patients within our clinic, virtual or not, within less than 7 days. I think it's very important in terms of maximizing their care. The importance of that, if we're telling our family members and our friends and our patients' family members and friends, we want to have warm handoffs. We want to have all the information available for us to have good continuity of care. And a lot of times when I'm have paperwork from the patient, it doesn't really help me in terms of doing the continuity of care. It's either CYA paperwork that's just tons and tons of drug-to-drug interactions, et cetera, but I need to know what happened. Were there labs drawn? Were there CAT scans that were done, et cetera? Are there medications that the patients have? A lot of times what happens, patients are discharged with a medication list and they're not told whether those medications have been prescribed or not. Same thing with specialty follow-ups as well. It's very important for patients to have and their family members to have that information upon discharge so that could facilitate the continuity of care. Also, the issue of being more lenient with regards to work releases or EDD as well too, because we're seeing as well, at least of the patients that I've been seeing virtually, tremendous diminished physical capacity, tremendous still respiratory compromise and fatigue, post-viral fatigue. And oftentimes we're still not understanding what this is because although we see that there might be remnant genetic material, unlike in terms of HIV, these latent particles cannot come back up and cause reinfection that we know of right now. We're still watching that as well too. But maybe the chronic fatigue that still continues, something up to 60 days or 80 days, could be a result of the chronic inflammation that's been exacerbated, occurred by the first type of the infection. Home resources, home health services. Oftentimes these individuals are unable to care for themselves and they do not necessarily want to go to a nursing home or not be able to go to a nursing home. So home health services are very important for us to implement and to try to get that going. The DME and walkers, my first COVID-19 positive patient was discharged home without a walker, without oxygen. And his O2 sats were in the 80s. We had to readmit him back to the hospital. And when we made sure that when he was discharged, we had all those things put into place. Again, the idea of a warm handoff between the provider and the hospital or the nursing home is so important, particularly with the patient's family advocating for these things to occur. Remote patient monitoring, although it might be constrained by insurances, this is a perfect time to implement these kind of systems where we can do frequent check-ins with our patients to see if there have been changes or exacerbations of their symptoms, their dyspnea, their O2 as well, and also adequate to mental health specialists. And also finally, when is it safe to return? The CDC basically says you have 2 consecutive negative nucleic acid testing tests within 24 hours. However, is that sufficient? How can you get to the terms of those NAAT testing as well? Or also, it says they go by symptoms after 10 days or 3 days without without fever and without use of antipyretics. Is that sufficient enough to actually go back to work? Is it sufficient enough for you to go back to school? And that brings us to the next point, which is germane to myself, because we're faced with what to do with the fall. It's been fine to be able to do schooling at home, but now there's a big push, particularly by the American Academy of Pediatrics. And I'll provide this citation in another format with regards to going back to school. And there's a big push to go back to school because they feel that there's been a lot of negative impact on children being schooled at home during this virtual testing. There's the loss of social structure. There is a question of whether it was reported that there is a 1 out of 5. The teachers sometimes pick up a 1 out of 5 abuse that happens at home, and that's the fact that this could be missing. The fact of the matter of of education and quality of education as well too. So this is something that to impact whether do we feel free and do we feel safe enough to bring this up at home. So I'm going to stop there, and I'll stop my screen. I'm done with that. I'm sorry, I'm having a problem with my computer. I apologize for the multi problems there with regards to the presentation.
That's okay. Thank you, Dr. King. I appreciate it. And later, if you have that video you showed, I was so impressed with. I'd like to, if you can get your computer together, I'd like that, the one you presented at a medical society. But we'll go on to our next person. But if you have that, I'd like you to prepare it.
Sure. I'll get another laptop. I'll leave and come back.
Okay. I'd like to introduce somebody who I've been a fan of for a long time. He's a major figure in the healthcare world in the United States. He's executive director of the American Public Health Association, Dr. George Benjamin. And Dr. Benjamin, can you start out telling us what that American Public Health Association is and what you do there, and a little bit about you personally, and then your talk?
Sure, folks. Hi, everyone. I'm George Benjamin. I'm an internist and an emergency physician. I did that for the first half of my career, and the last half I've been practicing public health. I've been the health commissioner for the District of Columbia, as well as the Secretary of Health for the state of Maryland. For the last 18 years, I've been the executive director at the American Public Health Association. APHA, we've been around since 1872, and we're the nation's, we're a nonprofit, and we're the nation's professional society of people that practice public health. Frankly, many of our members are the folks that are spending a fair amount of time running state and local health departments, doing a lot of research on COVID, and we're really the professional home for most of the people in the country practicing public health. So thank you very much, Randy, for giving me a chance to be here with you today. I just want to take on a couple things. Number one, just to remind everyone what the original plan was. The plan was, when we saw COVID coming, and we knew that it was going to, frankly, be a significant pandemic. And just know that many of us knew that it would be a significant pandemic, whether the White House knew that or not. But certainly the CDC understood it was going to be a challenge, as well as most of the senior people at the Department of Health and Human Services. And quite frankly, the original plan was that we knew it would overwhelm our health system. We were watching what was happening in other nations. And the plan was for us to basically shut down our society, move home as much as we could, in order to give, as everyone's familiar with the fancy concept of flattening the curve, to give our health system the capacity, not only, by the way, to manage COVID-19, but also to give the health system the capacity to manage all the other diseases. Since our health system, of course, is totally inundated with other diseases each and every day. Before we had COVID, most of the ICUs in this country were full of patients. ERs were overflowing. We had long waiting times for people to leave the emergency department to get to hospitals. And then you add an enormously infectious, clinically intense disease like COVID-19. On top of that, we had to retreat back. But on the other hand, everybody understood also that we would not be able to just simply go home and then 2-3 weeks later, return ourselves back to normal and pretend like this thing has gone away, because we knew it wasn't. And that the real solution to this, of course, is a vaccine. These kinds of diseases do best if you have a vaccine, could theoretically become a vaccine preventable disease. The challenge, of course, we knew that it took about 4 years for us to get the fastest vaccine that we've ever produced. And that was some of the components of the measles, mumps, and rubella vaccine. 4 years to do that. So the idea that we would be able to do this in 12 and 18 months was very, very ambitious. Having said that, there was reason to believe that was possible. And that reason for that was the fact that this virus is a SARS-2 virus. And we saw SARS-1 many years ago. And we had started looking at vaccines for that disease. That meant that we had already pretty much identified what the antigenic component would be. We knew that it probably could be made safely, and that one could probably make a vaccine that could respond and be protective. And probably, as you know, most vaccines, you got to spend a lot of time trying to find just the antigenic component, the the genetic component of that virus that would actually elicit immune response, and then of course, create protective antibody. So we were well on our way to doing that. The challenge, of course, was that, like many times in our research endeavor, the money ran out and they stopped doing the vaccine development on the SARS-1 vaccine. There were also some early developments on antiviral agents that they thought might work on SARS-1. So that gave us a little bit of a head start on this disease. Of course, the problem is that we're a big country, and very early on, this disease got politicized. And as many of you know, we had very, very poor national leadership on this. So people saw this hit the big cities that were highly populated: California, New York, parts of the East Coast, Midwest, places like Chicago. And quite frankly, many of the urban centers that got hit did not have the same experience as the rural states. Many of them were red states, like Texas and Arizona, the Dakotas. They did not get hit, at least initially, the same way as the urban centers did. And then, of course, as again mentioned, this thing got very politicized. That resulted in big delays in those parts of the world that weren't paying attention, frankly, to doing the same kinds of disease control and capacity building that they were trying to do in some of the more populous states. And quite frankly, now those states are getting hit. They're getting hit. Florida and Texas and Arizona are getting hit with the outbreak now, and seeing exactly the same experience that our more populous states, New York and most of California, got hit with. Now, having said that, we always knew that we were going to have to reopen society, and the problem again is that many of those states also began to reopen too soon. They opened too soon and too fast. So we're now having an enormous resurgence around the country. And I just have to mention that disease anywhere impacts us everywhere. So we are, quite frankly, the nation with the most cases, with the greatest disease outbreak. And we're seeing that in other nations have basically locked their shores and their borders to us, because we are the nation with the biggest outbreak right now. Dr. Maxey talked about the fact that we've already got over 2.8 million cases in the United States and over 129,000 and growing, almost 50,000 cases a day. And that's growing. We're gonna probably hit 100,000 cases a day in the next month. And this is going to continue. But by the way, we only have somewhere between 5 and 7% of the nation that has been exposed to this virus. And if you think about that, that means somewhere around 25 million people have had the disease in a nation with over 320, 330 million people, depending on how you count the folks in the United States. So we have a long way to go to either everyone getting this and getting herd immunity through 70% of us getting it, or a combination of herd immunity and vaccine. The good news is, of course, if there is a good news story here, is that clinically, we've gotten much, much better at understanding how to take care of these cases. Using some therapies, remdesivir and dexamethasone, have been shown to provide some therapeutic benefit to classes and subclasses of patients. So we are getting better at taking care of these patients. And we basically have learned a lot about how to manage the airway and how to take care of these patients the most. So I'm gonna admit that as an emergency physician, one of the most painful revelations for me was that prevention works, and that 80% of what makes you healthy occurs outside the doctor's office. With that in mind, the most important message I think that we can give our communities is that we're all at risk, period. We're all at risk. Some of us get sicker if we get the disease, and that tends to be African Americans because of the fact that we're public facing, so we're much more likely to be exposed. the fact that we have chronic diseases more than whites, so that we're more susceptible, and the social determinants of health, which have all put us at risk and also contribute more to our exposure and our susceptibility. If I can say one message that we ought to continue to reinforce to all of our citizens, that the one thing that we can do is the non-pharmacological interventions is masking, wearing a mask. Absolutely wearing a mask works. No doubt about it. Growing amount of evidence that it reduces transmission both for the person infected to other people and to those that are uninfected. So everyone should be wearing a mask anytime they leave their home. Secondly, we should practice physical distancing. While 6 feet is the magic, distance, because on average, that's where the virus kind of falls from the sky and hits the ground. We do know that aerosolization exists, and so it's not perfect. So obviously, the further away you can be, the better. But 6 feet, for the purposes of messaging, is the distance. And washing your hands. Hand washing continues to be an extraordinarily effective public health intervention, not just for you infecting others, but for you not self-infecting yourselves. We have failed as a nation to give a strong, clear, consistent, and coherent policy message and health communications message. But we don't have to, spend the next 6 months with the same failures, and I admit they're failures, that we did for the last 4. We can do a better job of educating our community. That's particularly important to communities of color because we're getting a large number of misinformation. That's just information that's being passed around that's wrong, and disinformation from people whose motives are clearly to not be in our best interest. So we have social media posts, we have Russian bots, we have people who are purposely sending information and picking on the African-American communities and the Hispanic community, I might add, mistrust of medicine, physicians, and authority to give us bad information. So getting the right information is very important. So with that, I'll stop, and Dr. Maxey, I'll turn it back over to you. Thank you very much for the opportunity.
Thank you very much, Doctor. I appreciate you so much. There are a number of other physicians that I'm going to call on. Dr. Ron Bailey has been with us almost every week, and I understand he has an engagement shortly. Dr. Bailey is a psychiatrist. He's the Associate Dean at Drew University and Chairman of the Board of the Cobb Foundation. And Dr. Bailey? Is Dr. Bailey still with us?
Absolutely.
I'd like you to have a brief word before you jet off.
Oh, I appreciate it. Got an earlier double book today, but thanks very much. I just commented a great program material today. I'm actually in Houston today, so very happy to hear Dr. Daly's comments. I mean, the reality is, I think epidemiology, I think those issues are huge for us, kind of have always been, but so many, I think, of our patient groups, that to think about, I think, at that level means a great deal. I think for me and many of the patients that I take care of, I think, in a psychiatric hospital every day in Los Angeles, these more recent comments, I think, by Dr. Benjamin's, the public health issues are remarkably important. I also would support that we have had some success in our hospital, Ketchum Hospital in Los Angeles, managing this issue regarding getting patients and staff to fully buy in. So in my one comment today, I think there's a lot to be said psychobehaviorally on getting patients to realize that this is a long-term concern. It won't be 2 weeks or 2 months that you kind of start and stop. We really are in the midst of kind of changing everything about what we do. I make it akin to my staff and my patients that there's a time point in our lives we go to the airport and we kind of we'll zip on through and we get there in a half hour for the flight and we catch the flight. And we all have changed our behavior. We get there, 2 hours early now, and that'll never change again. So my single comment today, I think, is the value, I think, of repetitive messaging and change in behavior, I think, is a key psychiatric concern that's going to be key here. Get people to think that the realities regarding disinfecting, hand washing, and wearing a mask. Those are behaviors that I think are here to stay. I think that those points were made very strongly today. Very good comments, I think, by the speakers today.
Well, thank you, Dr. Bailey. Is Dr. Keith Norris on? Is Dr. Keith Norris on the line? Dr. Norris is professor of medicine at UCLA, and I just found out this morning that he gave grand rounds and at UCLA and talked about race and racism. I hope he does sign on. But let's go to our other speakers who are with us today. Dr. Janine Daly, infectious diseases, Dr. William King, internal medicine, HIV, and Dr. Georges Benjamin. There are a number of questions that have been raised, and I'd like you to address them, and we'll open the floor if people would want to put questions in the chat. Michelle will read them. But the question been raised about the safety and necessity of our kids going back to school. There's been the question of a rapidly rediscovered vaccine. And we know there are issues, especially in our community, about vaccines in general. There are also the issues, what happens, and I got this from Dr. Natalie Carroll, that she had been delivering by C-section babies whose mother have been recently deceased. And how does that COVID affect them? And also that she's been advising mothers not to breastfeed because the virus is passed in the milk of the mother. So with that being said, let me ask our speakers to comment on that while we collect questions from the chat room. Michelle and Simon, are you looking at those questions? Are there any?
I sure am. I'm ready when you are.
Go ahead.
Are the doctors responding? You want me to go ahead with the?
Go ahead with the question.
Okay, so Doctors Daly, King, and Maxey, could you please address the recent claim by a certain elected official that 99% of COVID infections are totally harmless?
That would be the President of the United States, POTUS, and Dr. Janine, would you address that? And actually, all the speakers, I wish you'd address it.
This is Georges. Let me just suggest that we should ignore everything he says, and pay attention to the scientists who know what they're talking about. And I'm not making a political statement. He's not a physician. He knows nothing about healthcare, and has done nothing to inform himself. So, quite frankly, the idea is that we should ignore that. And the short answer to that question is that while probably about 80% of people who get this disease don't have a lot of symptoms with the disease. Just about everybody has no immunity to this disease, and almost everybody who gets exposed to it will catch it. But they may not have severe symptoms, but we don't know. We have no idea. There have been people that have had mild symptoms and have been found later to have severe restrictive lung disease. So we don't know what the clinical course of this disease is for everybody, or the clinical soliloquy.
Thank you, Dr. Janine, you care to add something to that?
And the only thing that I would add, or a couple of things I would add, one is, a percentage means that you have a denominator. And given our whole testing issues, we don't have a denominator. We don't know how many people have actually been infected. So it's hard to say, a percentage about anything right now. We have estimates based on the people that we do know have been infected and what's happened to them. But ultimately, we really don't know. And, and I just reiterate what Dr. Georges was saying is that we don't know what the long-term implications are of this disease. We have people that, get better when they're in the hospital and they go home, and then they end up having to come back in. When we do repeat imaging, we're seeing a lot of scarring within the lungs. There's this whole discussion about this inflammatory syndrome that we're seeing in children causing problems with the heart. There's this discussion about increased risk related to thrombosis. So, we really don't know. We have a lot of asymptomatic infections. There's this whole discussion about excess death rates that aren't officially attributed to COVID. And we don't know how much of that is undiagnosed COVID versus, people not being able or not accessing healthcare because they were afraid to go or weren't able to go. So, we don't know. And I'll just leave it at that.
I'm going to add something, and this, I swear, is not political. But I think, contrary to what most people think, that the President of the United States is extremely smart. And he is giving not coded, but obvious misinformation and misdirection to cause confusion, especially among those of us who may be more or less uninformed. And he does it in such a way, the best way to tell a lie is to have part of it be true. And he's skillful at this. And the main genesis of this call is to have vetted information from people that are like us, that are trusted, have studied, and we can give the best information we can for today. Now, we may have to modify it as we go forward, as we learn more and more, but you can bet it's done from a position of love, and we do care what happens to our community. So we try to give you what is best in information. Michelle, anything else in the chat box?
Just, Dr. Maxey, just the last word I just have to say.
Okay, I'm sorry.
That's absolutely fine. The only thing I would add on to Dr. Benjamin, Dr. Daly's comment is that people are following that information. Right? This disease process, the use of masks has been politicized and weaponized as well. And so we need here on the call, and we need when we go out into our outside work and our outside relationships to give the true information, because people are becoming sick, people are becoming dangerous. We're flaunting all the public health measures outlined by Dr. Benjamin.
Thank you, Dr. King.
Thank you, Dr. King.
Michelle?
Yes. Okay, so please speak about the false negative of the RPR test and the false positive rate with the antibody test, and how often one should get tested if one is living with others.
Okay. One of the speakers want to grab that one?
Sure. Well, I just looked at it when I was offline. I tried to find that. I went to the CDC, I went to FDA. I could not find that false positive rate with regards to a confounder with the RPR. I've seen it with other diseases, but not with syphilis. And so I really would like to find out where they got that information from, for one. The other issue with regards to utilizing an antibody test and how often we use it, we don't really know, I would say, and from my perspective. And one of the reasons is that we don't, not everybody basically is creating antibodies to that could be analyzed, could be seen by these tests. It also depends upon at what point, the time of the disease process where you can try to devise antibodies as well. So utilize, and the other thing is happening is compared to SARS-1, we're finding out the SARS-CoV-2 antibodies don't last very long. So not only do you have a weak immunogenic response with regards to antibodies, these antibodies that are finding out and looking at 6 months later, the antibodies might even be present as well too. So we're having a really tough time on how to use these diagnostic and screening tests in terms of taking care of individuals. I think it goes back to looking upon the art of medicine and communications with fellow physicians and providers such as ourselves. So although the CDC says within 24 hours is a condition to go back to work, as well as utilizing the antibody test, we really haven't had a good guideline with how to utilize that. I don't know what Dr. Daly, Dr. Benjamin feel.
Thank you. Dr. Daly, Dr. Benjamin, any comments on that question? And let me add to this, that there's been recent reports that we know that viruses mutate, and we I'm led to understand that this virus has mutated to more virulent pathogen. I'd like some comment on that.
Well, let me just respectfully quick one thing. It's not more virulent, but it is more infectious. So just that one point. And yeah, our understanding of the antibodies prevalence and how long it stays around, it's real clear it doesn't stay around as long as the SARS-1 virus did. What we don't know though, as you know, whether or not your bodies get some immune memory, because even though the antibodies may go away, you may very well be fully protected, but we don't know that. Now, you know, the way you do that is to take people that have been infected and have recovered and then re-expose them. Now, you know, the question is whether that's an ethical test or not. Most folks would say that it's not an ethical thing to do because we don't have a good therapy, that if they get sick, we can treat them. So, but the natural experiment is occurring. So you go to places like New York and California, where there are lots of patients who have, you know, people who have been infected, a lot of the police officers, a lot of the healthcare workers that are now back in the environment. And so we're now back public facing again. The question would be doing the epi study to discover them. Now that they've gone back to work, they should continue to protect themselves, but do they get sick? And one can do that as a natural history study, probably ethically, because they're going to go back to work anyway, and we could probably study them. Dr. Daly?
Yeah, I don't have a whole lot to add. I think one thing is just, you know, we've got all of these antibody tests that are available right now, and we don't really know which ones are more reliable than others. You know, right now it seems like the antibody test is most helpful from an epidemiologic perspective in terms of getting that denominator that I referred to before. But there hasn't been a lot of systemic study to try to do that. I know a few public health jurisdictions have looked into that. But again, you know, we don't know how long, you know, the immunity will last. We know that it's a single point in time. And just even aside from the SARS coronaviruses, you know, the routine coronavirus, you know, that's in the community, you can get over and over again. So, you know, there's no reason to think at this point that that's not possible with the SARS-CoV-2. And so I think that just remains to be seen.
Let me ask Dr. Goffney, you're out in the hospitals every day. How has COVID impacted the patients that you see, and do you see issues out there?
Yes, thank you. There are a lot of issues. I think the biggest impact is on the staff. I have seen nurses basically quit if they were within a year or two of when they anticipated retiring in the first place. Now that we're seeing an increased number of COVID patients and the nurses are being assigned to take care of those patients, they are simply starting to call in sick, but basically resigning. And so that's one of the big impacts. I've seen people from janitors to, I guess, all level of employees in the hospital are more and more concerned about the impact that their exposure might have for themselves and their families. So that's a big consideration. It would go to the well-being aspect of you know, what we have to deal with. Certainly from the patient perspective, if you contract this disease, and I've seen 3 or 4 patients become infected simply because they were in the same room as a patient who was an unknown positive. So patients get transferred in, especially at the LTAC facility, get transferred in as a quote unquote negative, and they're housed with 2 or 3 other patients in the same room. And then we later find out that one of those patients is positive. And so I've seen other patients in the room become positive because of that close association over time. That seems a little unfair. It's happening more and more. One of the patients in particular was just intubated yesterday, and You know, she had come in as a negative and fairly young lady in her late 40s, who now has a significantly smaller chance of surviving just by her association with another person in the room. So there are a lot of effects. I don't know where it's going to end. If we start to lose our healthcare workers because they're quitting or just afraid to participate, then I think that portends a lot worse outcome for the general public.
Is Dr. Hawkins still on? Dr. Wallace, I believe you just returned from Lagos. Is that true? And are there any issues with COVID that you could speak on briefly in Lagos, Nigeria? You have to unmute.
No, I haven't been to Lagos, but I've been in touch with people there. In Nigeria right now, I think the latest figure is about 25,000 COVID patients to date. In Lagos alone, that's where the bulk of it is. Let's see, and Lagos recorded about 16,000 to date. The country has had about a little bit less than 650 total deaths, with about 5 major politicians that have died. And that's, you know, when it gets scary, when the secretary to the president dies of COVID, when a state governor dies of COVID, a state ex-governor dies of COVID. So it's been in the news. Most of the spread now is community spread. They diagnosed, tested, they're testing more and more. And as of yesterday, about 600 or so new cases. The government has built a lot of isolation centers in different parts of the country. And once you test positive, you get taken to an isolation center. So most people are in the isolation center. And the problem is they claim it's more political because people are spending more than 14 days in the isolation centers. We don't understand why. And in the isolation centers, they are treating and discharging quite a number of them. The mortality rates, like I said, is about 3%. Most illnesses are mild to moderate. And in the isolation centers, they don't necessarily give them vitamin D tablet, but they mandate them to go out in the sun twice a day and be out in the sun for 20 minutes. And most isolation centers, while they're out in the sun, the government provides a musician that plays music. So they're kind of having a lot of fun out there in the isolation centers. I am on a Zoom meeting. They're having a lot of fun in the isolation centers. They're getting better. I understand that they are treating them with anti-malarial chloroquine. They're using vitamin C. They're using antibiotics. And there are some special hospitals for severely ill patients. And those special hospitals are designated by the NCDC, which is the National Center for Disease Control. So those are designated NCDC centers. And those centers, those hospitals have a lot of protocols for COVID patients. I understand that they are going away from intubation. So they are now intubating less patients because they are treating the disease early with either augmentin or azithromycin with antimalarial, vitamin C, zinc, and a lot of sunshine. They make them drink at least 1.5 liters of fluid a day. Yeah, Now, the problem that they are having in terms of antivirals, I understand that they have not been able to get remdesivir for the severely ill. They are trying to, some centers are doing their own convalescent serum for the very sick. It's also what I understand. In fact, there was, regarding remdesivir, there was a former governor who died, and they say that he could not receive remdesivir. I don't understand that. They said that the government had actually approached Texas and NIH, but that Trump has some military law that remdesivir should not be shipped outside the country. So they couldn't get it. And they tried to get it from India or somewhere else where it was manufactured. And while this guy was dying on his sick bed, they had a private jet go with tons of money to try and get remdesivir, but whoever went came back with some generic that didn't work. Well, the guy finally died, but that's the story out there in the media. So they have not been able to get remdesivir. I don't know if they're using Tamiflu, and I don't know if they're using any of the antiretrovirals for HIV, but most patients are being cured and going home. Again, only about 600 and something out of 25,000 positive tested have died. Now, there are some states that they are not testing, like some states in the north, they're not really testing. The government kind of drives away the UN and WHO people, tells them that there's no COVID, and then when they come into town, makes them quarantine for 14 days before they can even get to a hospital. So, and then in those states, we hear that people are just dropping dead, and they say, no, they're dying of malaria, they're dying of some other diseases. So those ones we really don't know, but the federal government is kind of stepping in more and more. So there's more transparency, more testing being done. But overall, just like other Africa countries, we haven't had much death. So we are not sure whether the protection is the heat, the high temperature, the humidity, or maybe because the people just have very potent immune system because they've been exposed to so much more before. And so that's the situation. But overall, they think that that 26,000 diagnosed is a very, very poor estimate. They think there's a lot more that are positive, but they're not being tested.
Well, thank you, Dr. Wallace.
That's it.
Going forward, and this is a question to Dr. Benjamin, Dr. King, and I want to call you Dr. Janine, but it's Dr. Daly Garnes, and to give you your propers. This is resurging. What can we look forward to? What can we tell the people listening in that we're in for the next, is it a few weeks, few months, few years? And how do we protect ourselves? What is going on?
Dr. Massey, while they're thinking about that, I'd just like to jump in. There are four or five more questions and comments in the chat room, which these responses might speak to. So just want to put that out there.
Okay. You want to ask the questions? Go ahead.
Sure. So the world's health community is being reactionary by necessity. SARS 1 and 2 started in the wet markets of China. Is there something the world's health community should be doing to prevent SARS 3?
Yeah, this, George, is two things. Stop encroaching on the habitat of other animals, to start with. And number two, get rid of the wet marks. And stop, these are all zoonotic diseases, and we need to do a much better job of putting firewalls up between people and the food that we eat and how our food is prepared.
Excellent.
Thank you.
There's a concept known as the One Health concept, where people really look at the interaction between human health and animal health and environmental health. And I think the more we invest in that, the more we'll be able to, one, have better surveillance of these things before they get to this point, and to be able to prevent them.
Yeah. Surprisingly, the world is an ecosystem. And, you know, I kind of cynically remind everyone that the planet has decided that these pesky things called humans are getting in its way. And it, you know, we're heating it up, we're destroying the environment, we're throwing things in the water, we're killing the other creatures. And, you know, in many ways, the way to think about this is the planet is pushing back, and we need to step back as humans and rethink about all the things we're doing to destroy the planet and how we're living.
Okay, the next, thank you for that. The next questions have to do with a little bit about testing and antibodies. So the first is Farrakhan put out a call to our health professionals to vet any vaccine that they come out with. Can we as a group respond? And then there's one about are antibodies not found at all, or are they found at a very low concentration? And the last is, some testing sites are antibody sites only with the finger prick, and the persons believe they have been tested for COVID. Please expound on this belief.
So talking about the antibody questions, because they're a little easier to address. So one, remembering that any of these tests are one point in time. So, and then, you know, the distinction that we haven't clearly made during this particular conversation, but just again, making sure that we're all on the same page to start with, is that you have the nasopharyngeal test that was mentioned, that tends to be nasopharyngeal, that's looking for the genetic material of the virus, which means that you actively have the material of the virus in your body, versus the antibody test, which shows that your immune system has seen the virus at some point in time. And as has been discussed previously, we don't know how long those antibodies will last. So we can't tell from that antibody test how long ago you saw the virus. We just know that you have seen it. And we don't know how long those antibodies will be present, that they may go away and be undetectable at some point.
Thank you, Dr. Daly. That clears up a lot for us laymen out here who don't know the difference between the actual testing and the antibody testing, so appreciate that.
Welcome. It's a very common question. And so, you know, when we talk about getting tested with the nasopharyngeal test, that just tells you at that point in time. So we're not detecting it right now. But if you're around somebody today, you may have it in another week. So, you know, there was a question earlier about how often to get tested. And I don't think there's a clear, you know, Dr. Bidgen, you can speak, but I don't think there's a clear recommendation for how often to get tested. But I think during this time, until we have a more definitive answer, you should expect to get tested more than once, like several times.
Yeah, there's no clear guidelines yet, quite frankly. And, you know, the challenge is that if you're in an occupation that's out and about, you need to be tested much more than those of us who are able to do the, you know, work from home. And you know that we've never fixed the supply lines for testing, PPE, or really anything else. And so as we return to our environments, going back to work, that will require more testing and more use of masks and more use of gloves. So if the government does not fix the supply lines, then we're going to be opening and closing much more vigorously than we're doing right now. And in fact, we're going to be doing that anyway. So we might as well just get used to it until we get a vaccine. And yeah, obviously we need to be on top of any vaccine that's produced. And I know there are some amazing people of color at the NIH are involved in some of these vaccine trials. The tragedy is we're not seeing them, and we need to see them, get them out, get them speaking, so that we can build some confidence that there's some people that look like us in the room, and they are. I don't remember her name, Randy, but Dr. Maxey, but I forgot the sister who's at NIH, who's just an amazing immunologist, vaccinologist there.
I don't know her name either, but let me put this comment in question. One of the reasons I was so happy that Dr. Daly Garnes was on, and I still, even though she's a very adult doctor, I look on her as a kid because that's when I met her. We need to have the same way we have these STEM centers trying to create Blacks to be engineers and scientists and technicians. We need to create a real push on Black people going into medicine and healthcare and research. The same way we encourage our Black kids to become police. We need to get in all of these fields so we don't have to be talking about we're unfairly treated, because we have a presence in those areas. And I know that in Cape Town that our friends Betty and Hal Walker have created a STEM cell, not a stem cell, but a STEM center all over the country of South Africa, asked to do that by President Mandela. And we need to really put a push on getting our young people into the issues of healthcare and research. There are not enough of us there. I'm tired of seeing Dr. Fauci. I want to see somebody who looks like us up there telling us what to do. Are there any other questions, Michelle, in the box?
Yes, sir. Okay, with respect to mental health, what mental help is being given to doctors, nurses, janitors, etc., who are dealing with COVID patients and the associated stresses? I force a mass PTSD issue with our healthcare workers and frontline workers. Are any of the doctors implementing de-stressing programs for their staff?
I want to have someone address that. Dr. Bailey had to leave us, but I'm going to add something to that question. I'm a 100-year-old frontline health provider, and I'm scared to death, but I'm seeing patients every day. Dr. Michelle Clark, I believe, is on the line. She's a noted psychiatrist, had her medical school at Columbia University. When I first met her, she trained after that. And tell us a little about you, Dr. Clark, and then can you address some of that question?
I certainly can. The Black Psychiatrists of America, our CEO is holding a weekly radio program. And I can send you the information, Dr. Maxley. Dr. Patricia Newton is the CEO and medical director of the Black Psychiatrists of America. She's holding a radio program. The president of the American Medical Association is a Black woman physician, Patrice Harris. And she has held coalition meetings with our NMA president, Oliver Brooks, the president of the Latino Psychiatric Association, the president of the American Indian Association. And they're talking about programs to start through their organizations. Locally, I have addressed the National Coalition of 100 Black Women, and I'm happy to address anybody else. Hey, William, how you doing? I just saw your picture there. I think the main thing is to recognize that psychiatry is the unrecognized primary care practice. And it's important to refer your patients because many Black patients, I'm shocked actually when I addressed 100 Black women about how little they knew about mental health and how it still is stigmatized. And nobody, quote unquote, wants to be crazy. Crazy is just an insult. Psychosis is the very little of what we treat. We treat mostly anxiety, the anxiety of being Black in these Americas, particularly in the United States of America. And we do that all the time. But it's important for the identified primary care practitioners to encourage their patients and support them and demystify and destigmatize mental health services. I don't know if that answered the question. I only heard part of it. Could you repeat the question, Ms. Michelle?
My pleasure. It was what mental help is being given to doctors, nurses, janitors, et cetera, who are dealing with COVID patients and the associated stresses.
Mm-hmm.
And then
the Black psychiatrists, I'm sorry, did I cut you off?
Yeah, I wasn't sure if you heard the entire question. The second part of it was, I forced a mass PTSD issue with our healthcare workers and frontline workers? Are
Right.
any of the doctors implementing de-stressing programs for their staffs?
Yes. The Black Psychiatrists of America, oops, what'd I do?
You're okay, I can hear you.
Okay, as long as you can hear me. I don't know what happened to the meeting, but, oh, here it is. They're having a quarterly, and I'll send you the webpage and the link, a quarterly open town hall for all Black people, anybody actually, who's a healthcare worker, to talk about the trauma-related syndromes, including post-traumatic slavery syndrome, which, although Dr. Joy McGrew has popularized, it actually was a term that was created by Dr. Patricia Newton. And also the trauma of being scared yourself, being afraid for your family, dealing with all of the other issues we have in the context of all of the health equity issues that we have. It's a huge and broad scope to cover, and there's going to be tremendous mental health fallout from the isolation, plus all of the trauma. I could spend the whole 2 hours on that, but unfortunately, I'm going to have to go in a little while, but I'm glad I checked in so I could at least address that question and any other questions you may have about mental health.
Well, thank you very much, Dr. Clark. Any other questions? I want to make sure we get to as many questions as possible, and I also want to give some other health provider physicians a chance to make brief comments if they're on the line.
Yes, thank you, Dr. Maxey.
Hey,
There is another
Jerry, I
question.
haven't seen
Have we
you in years.
forgotten? Have we forgotten about the underlying health conditions that are causing deaths every day and some things that we can do to lessen those symptoms and the effects of those symptoms? I would like to talk a few minutes about some of the things that we can do as far as prevention every day.
So have we forgotten the underlying conditions
that are causing deaths every day and some of the things we can do to lessen those symptoms and the effects of those symptoms?
Right, let me address that. I came up with a statistic after 9/11, and that was we were also blown away that over 3,000 to 4,000 people died in that day from those Twin Towers going down. And it occurred to me that just from cardiovascular disease, including not only heart disease, kidney disease, obesity, and diabetes, that more than 3,500 people a day are dying or coming close to death. That number pales when you compare even the COVID to it. It is very important what we do to our bodies every day by the way we eat, by the way that we don't pay attention to our environment, to our relative lack of cleanliness. And I'll speak and say relative, that in certain other communities that are not of color, the lack of cleanliness is even worse. So one of the silver linings that will come out of this is that at least we've learned to be much more attuned to keeping our bodies clean, our hands clean, our food sources clean. We've learned to eat a plant-based diet, I hope. And it is so important that we adhere to some of God's dietary rules. And we're going to have a program in the next few weeks that will go around the prevention and especially dietary issues and preventative issues. And that will be very important. And we have a number of people who've been a part of this call who have a lot of expertise in that. So we will continue to push that. But that whoever asked that question was very precise in what
that was me. That was Thurston Bilal. And one thing I want to tell everybody is dehydration is one of the major problems that we deal with across the board. We don't drink enough water. And most of the time we are in a dehydration deficit. So think about it. For every day that you didn't drink half of the ounces. So if you are 100 pounds or 200 pounds, you 200 pounds, you need to be drinking at least 100 ounces of water every day. So every day that you didn't, that's a deficit that's affecting your body. And that's one of the major problems that's showing up. And also the electromagnetic frequencies and what we're eating. So we need to consider all of those things in this cross section of our health. It's not just COVID.
And that's very important. I thank you for that. And when we get ready to put on that nutritional section, I'm going to talk to you about that. Those issues are very important. One of my former patients, Dick Gregory, had those as the most important things: the water deficit, sleep deficit, and he had one other. So we're going to talk to you about when we do that program. I'm going to ask our producers to help us put that on. Anything else in the chat box, Michelle?
Dr. Clark?
I just wanted to say that as Black folks, we also need our vitamin D. Many of us are vitamin D deprived, and that's very important for mental health. Also women, we need our pyridoxine, that's vitamin B6. Just take 50 milligrams a day, because most of us don't really know when we ovulate. So you need to have that to protect you against the hormone shifts that occur on a monthly basis. And those are the things that I do routinely with my patients. There are a number of other nutrients that I don't have right in the center of my brain right now, but I can provide them at a later point. And I'm sure the brother that just spoke, Mr. Bilal, I'm sure he can help us a lot with that. He's already given me some tips from the last couple of conferences.
Yeah, we're going to get him on with us. I'm going to give two of my other associates a chance. There was the Admiral James Johnson, who was the commander of Balboa Hospital. He's a surgeon, he's a Marine, and he was the administrator of TRICARE. So he's had a lot of experience. I'm going to ask Admiral Dave Brewer, who is not a physician, but he was the commander of the Navy healthcare ships, the Comfort and the Mercy, to comment briefly on what they've seen in this issue. Gentlemen, if you would mind giving brief comments on that.
This is Admiral Johnson. Thank you, Randall. I apologize to everyone. I always join this call late because I have a family call that begins at the same time every week, and I am the oldest surviving male member of the family, the pater familias, so that's not one I can get out of. But I've been listening, and a couple of things occur to me before some other comments. One of the question was asked, or Dr. Maxey raised the issue about educating our young people and getting more of them into health-related tracks. My brother, who just retired Thursday from his 36-year pediatric practice, he is chairman of the board of a charter high school here in San Diego, and his wife is the principal. And this charter high school is geared toward preparing high school students for, and middle school and high school students for careers in healthcare, not just doctors and nurses, but lab technicians, et cetera, et cetera. And that charter school's been going on for somewhere between 5 and 10 years, very successful. So there's that, at least here in San Diego, that's going on. Second, I'm a surgeon, and I've been sort of observing some of the interconnected pieces with respect to essential elective surgery, much of which has been put on the back burner because of COVID, because hospital beds are needed, operating rooms are needed, et cetera, ICU beds. But we got a big bill that's going to be payable downstream for a lot of essential elective surgery that's been put on the sidelines. That is not life-threatening if you don't have it, but it's still essential. I was just thinking of the dental colleagues who were completely shut down in just about every locale, and they're just starting to come back online. If you think about a place where COVID can be spread, working in somebody's mouth is ground zero. But if you think about all the essential elective dental work that's been put on the sidelines, and if it has to be re-put on the sidelines because of all these spikes, that's another bill that's going to be paid. And I was intrigued by the comment about whether or not remdesivir was available in Nigeria because of something Trump might have done with the supply. I believe that, and I believe this is good information, that Trump administration cut a deal with the main supplier globally of remdesivir so that 90% of their output comes to the United States. I don't know if that was done through a military contract or whatever, but there's probably some truth to the fact that it may be less available in other parts of the world because the U.S. has cornered the market on that. I believe there is some validity and truth to that.
Thank you, Admiral. I appreciate that. Is Admiral Brewer on?
I didn't see Dave's name come up.
Okay, he had called me, said he was coming on. Okay, are there any other, is Dr. Hawkins, any of other previous presenters on? You want to comment before we move on to the agenda? Okay, Michelle, anything else in the chat box?
Not at the moment. I just urge everyone to take a look in there and see if there's some information or questions or answers or statements that you're interested in or referrals. So, but no further questions at this moment.
Okay, Mr. Dr. Carl Brooks, do you have a question or a comment? I see you shaking your head. All right, I do want to make a brief statement before we get off the line. And many of you know the story of Paul, who wrote essentially the New Testament in the Christian Bible. And he was tasked by God to preach in Rome. But on the way to Rome, he was shipwrecked and stranded on the island. But recall that he was tasked by God to preach in Rome. And while they were able to survive, the shipwrecked people, on broken pieces, which allowed them to float to the island, another incident happened in that they built a fire from, I guess, logs and sticks. And as the fire got hot, the snake came out and bit him. And part of the lesson in that is that when you have a mission, which is to preach in Rome, there will be many distractions along that way to try to get you off of your game, off of your course. And in the process, as you turn up the heat, as many are doing now with this racism and these protests, and I'm actually so proud of these young white kids that are joining, most of them in earnest, to speak up for Black rights and brown rights, that it's important to stay on your mission and course, because when God says you're going to preach in Rome, getting shipwrecked, getting stranded on the island, getting bit by a viper will not stop you as a people from getting to Rome to preach. From a mental health standpoint, we know that many of us are undergoing stress, PTSD, anxiety, and we know there are all kinds of things. And I have to admit, I have anxiety about going to my office every day, but I know that I have an assignment. I've been told to preach in Rome. And all of us have that mission to preach in Rome. So that can lessen some of our anxiety about these distractions, who our president is, who the politicians are, who's opening up what. The only thing we have to do to get to Rome is to survive, which means protect ourselves the best we can. And every week we say we need to wash our hands with soap and water, and then use the alcohol, at least 60%, that we need to be eating a more plant-based diet. We need to exercise, we need to wear masks, we need to socially distance. Our main mission on the way to Rome is to protect ourselves and our families. We know that the children of Israel, when they came out of out of Egypt, they came out as millionaires. Going through this period of hazard for our families, we should use this period to create our businesses, our community wealth. We should be cooperating. We should building the thing that it takes to nation build when we get through this tunnel. To this end, we have created the Black Health Trust, which is a nonprofit. We have an EIN number, tax ID number. We have applied for tax exempt status, which we believe will happen in the next few days. We have retained a firm of Pratt & Johnson to help us have an internet presence, a marketing presence, a brand presence. We retain the services of a certified public accountant to make sure things are straight. We have various people assisting us to manage the call, and we're going to be hiring grant writers. We've created a number of benefits that people who join us, not as just viewers, but as members and supporters. There are certain benefits that they will be able to have from us, including second opinion expert. And many of you got a letter from me suggesting that we would be enamored if you could make a donation so that we can go forward with our plans. A number of people have been just working, putting up their personal funds. None of this is to go in my pocket or make me rich or any other people. But in order to grow from the 50 to 60 people we had online here on a Zoom call, we've gone to now where I believe we've hit 2,500 to 3,000 people viewing this call on the various platforms, including Zoom, Instagram, and Facebook. So we do have a website, which is blackhealthtrust.org. It is active. It has the videos from most of our previous meetings. It contains links to the CDC website, and we hope over the next week or two to put up other information on COVID and health in peoples of color that we have vetted. And we have a group of physicians who have worked with us for a number of weeks, and they're some of the most prominent physicians in our country. And they've been giving of information freely, and I certainly appreciate them. And we're going to ask many of them to be a part of the second opinion expert, which allows you for a small fee to converse or contact or have your medical records reviewed by physicians of color who are experts in their field. And part of the thing that we've tried to showcase here, you hear about all of the Fauci's and the other doctors that are on CNN and NBC and Fox News, but usually you don't see the doctors that look like us. Well, you're going to see them here. And they're all of note. They're all accomplished. And they are some of the best doctors in the world. And I've always said that nobody cares how much you know until they know how much you care. And so you'll be seeing other doctors come on that you haven't seen yet. You'll see some of the doctors that will be coming back, and many of them want to be a part of this team. So we appreciate you for coming on for this information. We hope it's been helpful. We want to codify it and have it available online. There's a way that you can register as a member. You can have your questions answered. And we'll be coming out with a blog, a newsletter, and maybe eventually a journal. I don't know about that. We're going to have a good relationship with the National Medical Association, the Charles Drew Medical Society, the Association of Black Cardiologists. We've got some dynamite Black doctors to bring to you, and I hope you've enjoyed our program so far. Are there any questions or comments at this point?
I just have a comment.
Randall,
I don't think we need to recreate the wheel. The journal needs more articles and more contributions, and I think we can make it more robust if we contribute there.
Okay,
Just
good.
Randall, this is Admiral Johnson.
Yes.
I just have one parting comment that just occurred to me, because most people probably won't have this information. San Diego Union is our local paper, and on the front page this morning, one of the articles referenced Black Lives Matter protests that were done yesterday on the 4th of July. And the article focused on surrounding suburbs as opposed to the city: El Cajon, Oceanside, Poway. I live in El Cajon. And the El Cajon group was about 300 people marching around El Cajon. And there's a picture on the front page. And based on the picture, I'd say you can see probably 50 of the 300, mostly young people, all races represented, the typical signs. The thing that I find most striking in this picture of 50 of the 300, I cannot see a single person who does not have a mask on, not one. You contrast that picture with pictures of Trump rallies where almost nobody has a mask on. Virus is apolitical, so maybe there'll be some natural selection over the next few months.
Excellent. I understand what you mean by natural selection, Admiral. That's cool. Let me ask something a bit different. Can the people on the phone call that are steering committee members just introduce themselves real quick and say where they're from? Starting with Michelle.
Hi, I'm Michelle Simmons out of Los Angeles. I'm a human resources professional by trade, and I'm a part of the steering committee of the Black Health Trust.
Hi, my name is Marlon Jones. I'm a CPA out of New York.
Hi, my name is Michelle Clark. I'm a physician originally from New York, trained at Harlem Hospital by Dr. Randall Maxey. But I'm a psychiatrist and I'm practicing in Contra Costa County, and I live in Oakland.
Hi, I'm Judy Maxey from Fort Lauderdale, Florida, member of the steering committee. I'm a retired educator.
Hello, my name is Carl Brooks, and I'm the retired President, Chief Executive Officer of the Executive Leadership Council, which is the organization of the top African-American business people in the country. And I'm a great friend and family member of Randall Maxey.
Dr. Maxey? Yeah, this is Tori Bailey, former educator and Director of Health Information and Chair of Health Information Technology in Los Angeles.
Mr. Pratt?
Hi, this is Martin Pratt. I am part of the steering committee here in Philadelphia, Pennsylvania.
Hi, this is Lamont Gibson. I'm a pharmacist in Los Angeles, 4+ decades, and proudly serving urban Los Angeles.
Mr. Ross?
Ross Johnson, Willoughby Avenue, publisher and brand consultant, living in the Washington metro area.
Linda on? Did I miss anybody, Judy?
Where's Judy?
Okay, I think we,
You got everybody.
okay, good. And very good. So I hope that you will respond to our letter. We'll be on each and every Sunday. I believe we have a program for the 19th. Who do we have? Next week is not the 19th though, right? So next week, I know we have, I believe we have Dr. Natalie Carroll, who's OBGYN. The following week, we have, who do we have, Tori, on from the police?
Deputy Chief Regina Scott, the first African American in the Los Angeles Police Department, female.
Okay. Well, thank you everybody for your time and your input. Any other questions? Is Bishop Pate on?
Thank you, Randall.
Okay. Is Bishop Pate on? Is John Sadukas on? Did you have the surprise guest? Then I go to my sister in Christ, Brenda Lee Yeager. Would you take us out?
I'm here. Okay, could we just take a nice deep breath together? And realizing that in God we live and move and have our being. In God, not separate from God, but in God. We can't go anywhere where God is not. So He's given us the ability to speak our word, claiming, as Jesus Christ says, speak the word and declare that it's so and it shall be so. So today I am blessing everyone on this call. I'm blessing every one of our family members near and far, surrounding us all in the love and the light of God. And may the peace of God be with us all. And our health is totally intact, and we surround ourselves with the light, love and the light of God from this day forward, and be a blessing and a light to all we come in contact with. For this and so much more, I'm so grateful. I simply allow it to be, and so it is. Amen. Thank you, Lord.
Amen.
Thanks to all of our speakers and participants. Thank you so much.
Thank you, everybody. Have a wonderful week. Stay safe.
Hey, Cher.
You too.
She's shaking her head like, don't say nothing else. Love you guys.
Have a great day.
Okay, Tori.
All right. Hey,
Okay.
Tori.
Hey,
Finally get to see you.
How you doing?
Her name is Tori, baby.
It's coming. I'm surprised it didn't pop up. The other day I was on a Zoom call and a picture popped up that was from my Facebook. I was like, what? How you doing, Martin?
I'm doing.
Wonderful, wonderful. Another great call.
Yes.
We'll continue to be productive.
As we should. Especially
Okay.
Randall pushing us.
Well,
Randall.
hey.
And Randall pushes. Yeah.
I do. Well, I look forward. You guys have a great week, and I look forward to talking to you on Wednesday.
All right. Be safe.
Okay, you too. Bye-bye.